So now we'll move ahead towards our much awaited panel discussion by Dr. Kaberi, Enhancing IVF Success, Strategies for Managing Challenging Conditions. So I would like to invite Dr. Kaberi. We all know her. She's Medical Director, Advanced Fertility and Gynecological Centre, New Delhi. Dr. Kaberi, welcome, Dr. Kaberi. So would you like to invite your panelists, Dr. Kaberi?
Sure. Thank you once again, ISAR, for this wonderful opportunity. And let me start by inviting my panelist, Dr. Anju Kanogia. She's the Director and Consultant at Ashirvad IVF Fertility, Jaunpur. May I have the next panelist? Dr. Pratibha Singh. She's the Senior Consultant in Fertility and Laparoscopic Robotic Surgeon at Lucknow. Dr. Saroja, she's the Senior Consultant and Clinical Director, Nova IVF. And Dr. Richa Singh from Lucknow, Director. Somebody needs to silent their...
I request Dr. Anju, please. Yeah.
Thank you. Dr. Richa Singh, Director, Urvava Fertility Centre, Lucknow. Dr. Ishita, Director, Upahar Nursing Home, Varanasi. Dr. Shweta, she is the, there's a lot written here. I think she's at the moment working at Nagpur Test Tube Baby Center, if I'm not mistaken. Yes, she's from Nagpur. Welcome, Dr. Shweta.
Thank you, madam.
Right. So I have the sharing rights. Yeah. So though today we are going to discuss the difficult clinical scenario in IVF and how we can enhance its success rate, we will start with a simple question first. And I would like to know who all of my panelists do not do IVF. Hello?
All please respond. If possible, all panel members, please on the camera. Signal is good.
So I presume all of you would either be doing or have a good knowledge of IVF. So this is a 27-year-old lady with 3 years of primary infertility. She is visiting your fertility clinic with laparoscopic findings of bilateral tubal block. All other investigations are normal and you've decided to go ahead with IVF. What factors would you double check to ensure that she has the best results? So what would be your preliminary basic tests? So I would request Dr. Anju to share her thoughts.
First of all, I would like to whether she is physical active or not, what is her BMI, and I want to know her lifestyle, and what is ovarian reserve, about her AFC, semen analysis of male partner, and rule out infections. Check mid-cycle ET also.
Right. So the reason we have put this slide is to, before we start on IVF and try to deal with the complicating scenario, our basic fundamentals must be clear. We should be sure that her endometrium is good, her ovarian reserve is reasonable, semen analysis, there's not much of motility, morphology, oats, and infection, fibroid, hydrosalpinges must be ruled out. So this would be a typical very good case where we would be expecting a good result. One thing about the mid-cycle endometrium, and this we will come in the next question, and perhaps let's go straight on to that to take. And now I will be asking Dr. Pratibha, how do you tackle thin endometrium in your practice? Before you answer that, what according to you is thin endometrium and how will you diagnose it?
If endometrium is less than 5 millimeter in the mid-cycle,
or if it is not triple line or vascularity flow is less, then we can say it is a thin endometrium.
Any of my panelists would like
I would
to
like
add?
to correct, as per the definition, it is 7 mm as the criteria in the mid-cycle. If it is not reached till 7 mm, then we call it as thin endometrium, and that's how we diagnose. So mid-cycle, we have to really evaluate the endometrial lining.
Yes, so I would agree with that most studies are saying 7 millimeters, though some have gone down to 6. And one thing very, very important, that it has to be a natural cycle, meaning you should ensure that the patient is not on any medications, has not taken any medications in the previous cycle, like contraceptive pills, clomiphene citrate, and on such a cycle, her lining must be measured. So, Dr. Saroja, how do you usually prepare the endometrium? Say we are talking, let's go to core IVF and you're preparing a frozen embryo transfer cycle. What is your usual protocol for preparation?
So first of all, we would assess like how the endometrium was like when we were simulating the cycle, or when we initially assessed if there was any problem with the endometrium or not. If the endometrium was good and no problems, we'll just start with the preparation. If there was any problems like beforehand, if the endometrium was thin, or if there was any doubt regarding the endometrium, then I would do a hysteroscopy. If everything is fine, then I would do, majority of my cycles would be HRT cycles. But if there is like a resistant to HRT cycles, we will go with ovulation induction HRT. And if they have adenomyosis or something, I will give like down-regulated HRT.
So what molecule do you prefer? What is the route and what is the maximum dose that you usually go up to?
So we give like estradiol hemihydrate as a vaginal route, and we give estradiol as an oral route too. So we give a combination of like oral, like majority of the patients we give 4 milligram BD and see how the endometrium is. Majority of the people respond, but if there are like diabetic or if there are elderly patients, we give mostly through the vaginal route.
So you start on day 1, day 2 with 8
Day
milligrams.
2.
Is that what
Yeah. Yes.
Dr. Shweta, Dr. Meeta, do you have anything to say on this? Your usual protocol for preparing the endometrium?
Yeah, ma'am. Actually, if most of the times we use a HRT protocol, and we start with the oral dose of 2 milligram twice, 4 milligram twice, thrice daily first, and then we increase, and the maximum dosage of estradiol, if required, mostly we give 8 milligram a day, but we can increase up to 12 if required. But most of the patients, they respond to 8 milligrams. And if the patient, we feel that in previous cycles or some problem with HRT protocol, then sometimes natural protocols or modified stimulated protocols also work for these patients if they are not responding to usual HRT protocols.
Right. So usually we would start with the slightly low dose, maybe 2 milligram twice or thrice, and then if needed, increase from the 6th or 7th day. That's the usual protocol, and we can start with 4 to 6 and go up to maximum 12, and that's the recommended dose. And natural cycle is a very good alternative way of even starting off your FET cycles. And I think Dr. Ishita is not with us today. Right. So Dr. Meeta, what other protocols apart from the HRT and the natural protocol do you follow?
Sometimes we can use tamoxifen if we are having thin endometrium in previous cycles. So we can use tamoxifen stimulated cycles also. Some patients respond very well to that.
Letrozole, HMG stimulated cycles as well?
Yes, ma'am.
Okay, Dr. Anju, when would you like to scope a patient with thin endometrium, or would you always do that?
Ma'am, when the endometrium on day 9 is less than 6 centimeter, I call it thin endometrium, and I want to increase the dose of estradiol, valerate,
No, my question
2
is, when would
mg.
you like to put in a hysteroscope in a patient of thin endometrium?
Yeah, ma'am.
Or
In next cycle, if patient is not responding, then I will
Mhm.
do subendometrial PRP to increase the endometrium and some metroplasty. Endometrial scratching I will do.
Dr.
Hysteroscope.
Pratibha, do you have to say anything on this?
In a patient of thin endometrium, if we are not, in spite of increasing the dose of the estradiol, the endometrium is not growing, then we'll plan the patient for in next cycle for hysteroscopy, and we'll see for any additions or any endometrial pathology or infection or tuberculosis or something might be there. Because of that inflammatory condition also, endometrium is not growing. And also the patient, we inject some PRP or subendometrial PRP to increase the thickness of the endometrium in this cycle.
Right. So one of the diagnosis is adhesions, and it is not complete grade 4 adhesions that respond to hysteroscopic treatment, but the initial adhesions, 1, 2, or 3 bands, once you put in an hysteroscope and you remove those bands, you get a very good response in the next following cycle. So a hysteroscopy can be very, very useful in a case of thin endometrium. We did talk about... Yes,
Can I
please.
add something, Dr. Kaberi? Actually,
Sure.
we all discussed that we start with a smaller dose, say around 2 mg TDS, and then that's how we see on day 9 and day 10. I would like to add on a point here. In my clinical practice, in my first cycle, if I have given a dose and up to even the maximum doses, the patient is not responding, I would rather prefer a next cycle with a little higher dose of starting the preparation for the HRT. And if again the second cycle also with the maximum dose does not respond, then probably I would like to take a decision for hysteroscopy if the ET is not improving. So I think one cycle, if one cycle, there might be that some endometriums have a higher threshold of responsiveness. So you let us know what is your take and how you would like to take it forward.
I
That's a
want to
very
add a
valid,
point.
yeah, may I? That's a very valid point. I think there are 2 points here. One is, when would you scope? Would you wait for a few cycles before you put in a telescope? And second is, how would you increase the dosages? So in increasing the dose, not only can you start with the higher dose in the next cycle, I completely agree with that. You can also use different forms of estrogen, like
Definitely.
has been mentioned, a vaginal route or a gel route, which some patients, respond to those routes better. Also, you can, our particular clinical experience, and we've also published a paper on the adjuncts that are used, though all these are still in the, we need more trials and we need more studies, but we did compare subcutaneous GCSF and we found a significant improvement. PRP and stem cells, again in the clinical zone and experimental zone, which has to be explained to the patient. But there have been, so yes, there are various ways in which you can
Adjuncts.
still try to improve the endometrium, but most of the consensus, especially if it has been a failed cycle, a previous outside,
Yes.
then definitely hysteroscopy would be necessary. And thin endometrium, there has been quite a few studies that have said that if within a few cycles there's no improvement, hysteroscopy will help you in, we need to carry on. I'll take the next question with somebody who wanted to say something is, what is your opinion on nutraceuticals in thin endometrium? Can I
increases
ask
the vascular.
Richa or Shweta
Yeah.
on this?
So my take on nutraceuticals is that yes, I do use many times along with my estradiol hemihydrate if I'm giving up preparations, and if patients are not responding, I would like to add on to some adjuncts, but I usually prefer arginine because it has been observed that it increases the endometrial flow, and I've many times seen changes in the endometrial thickness. And some antioxidants can also be added, but personally in my practice I am not adding antioxidants. I usually add arginine sachets and increase the dose of the estradiol, and then let's see how the body behaves. And if sometimes it does not respond, then definitely we look forward to PRP or GCSF, intrauterine instillation.
Right. So we basically, the various modalities would be hysteroscopy if needed, the various routes of estrogen, the adjunct treatment and PRP and stem cell. One of the very important things which may benefit the audience is this is when you are doing a routine embryo transfer cycle. You may or may not envisage thin endometrium in that, and start a cycle with a down regulation properly documented, either with low E2 or a baseline thin endometrium with no follicles. Even if there's a follicle, measure your estradiol, and if the estradiol is less than 60, only then start that cycle. Any cycle where there is any spotting or any fluid, please cancel that cycle. Do not use that cycle. Your transfer technique is very important in such cases. Persistently thin endometrium, we can go up to a few cycles with the various adjuncts that have been discussed. But at some point, we need to decide that enough has been tried and various options need to be given to our patients. Now we go to the very, very important, which most of us are facing in our practice, a 32-year-old with an AMH of 0.6. And my question to the panelists is, do all women, according to you, with low AMH behave the same? And she's very, very keen on self-egg IVF, as is with most of our patients. And what strategies will you keep in place to optimize her outcome? So can we start with Dr. Meeta, please?
Yes, ma'am. Nowadays, many patients, they are coming with low AMH and at this age. And I have seen many patients responding in a different ways, like with a 0.5 AMH or 0.3 AMH. Some patients on stimulations, they may be producing more than 4-5 follicles. Some they are not responding at all, and some 1 to 2 follicles only. So my take on this low AMH patients are usually we should definitely give a try by stimulating them. And even if 3-4 follicles are developing, we should go ahead, and they might give a good number of embryos as well. 1 or 2 embryos at day 5 also maybe sometimes possible.
So what, according to you, is the most important prognostic factor?
Can I add on, Dr. Kaberi?
Let her just,
Sure.
Just 1 second. So I think comparing our ultrasound AFC on day 2 with the AMH is most important. Sometimes we see discrepancy on our ultrasounds, and then these patients, they respond well.
Yes, you wanted to add on something?
Yeah. So what I wanted to add on is that every low AMH patient is not going to behave the same, because as per Poseidon criteria, we group people, whether it is Poseidon 1, 2, 3, and 4. And age definitely plays a very important role, because in younger patients who are less than 35 years of age, we tend to have, even with low AMH, we tend to have better quality of embryos, and they have a better chances of conception. And it has been, various studies has been seen that they have better implantation rates, better clinical pregnancy rates, and lower cycle cancellations, and the lower miscarriages rate. So that is number one, that we have to understand and counsel the patient depending upon what her age is. And secondly, we just also have to see that if it is isolated low AMH, which is just 0.6, or there is an associated rise in the FSH and LH hormones, because if it is high, it is going to be a poor responder and it has more chances of cycle cancellation. So in my opinion, I would like to first counsel the patient, number one. Number two, I would like to evaluate her. Apart from AMH, I would like to get her hormones done and see whether she is downregulated or not. And in the meantime, when I'm probably if she's coming to me and in my mid-cycle and mid-cycle and I'm planning her stimulation in the coming month, I would like to add on to some adjuvants to kind of increase her ovarian reserve or quality or to better her cycle outcome.
Yeah, just let me hold on to you here, Richa. So very important point, age and AMH and AFC, these are the basic things, and lower the age, higher is your prognosis, and the counseling must go that way. Also, when you do your ultrasound, there would be women who've had previous unilateral ovarian surgery and the other ovary is absolutely fine and her AMH is low. So these women have a better prognosis than any other woman with the same age with both ovaries, suboptimal. So single ovary working better will still have a better chance than with similar AMHs. So that is one important thing. The other thing which I feel we all as IVF, specialist must explain to our patient is the fertility pyramid. And whether it is low AMH or normal responders, that the number of follicles, because as we are doing the follicular scans, we see how anxious they are to look into the ultrasound machines and follicles, and somehow in their mind, for those who are not as experienced in maybe it's the first cycle or the second cycle, they would correlate follicles with perhaps embryos in the back of their mind. And it is very important to tell them again and again that follicles, eggs, embryos, day 5, good embryos, there's a downhill journey. And that's how we will reach to at least 1 or 2 good embryos to give you the good success rate. So this is something, and of course, we will now come to the important points, Richa, that you were discussing. So Saroja, can you please tell us what lifestyle measures would you look for specifically, and what would be your advices for them?
So I would advise maintain the optimum weight. So do appropriate exercise to maintain your BMI below 25. Then appropriate diet, like with a balanced diet that you have to be. And if anybody is smoking, because smoking nowadays is quite common among women as well, so I'll ask them to stop smoking, because that can dramatically decrease the number of oocytes. And if they are taking alcohol or drugs, advise them to act against it and maintain a healthy lifestyle. Decrease the stress as well, because stress also seems to play a role in decreasing the oocyte count. And also counsel them this might help. And even like if you get one more egg with all this, that will form a good embryo maybe.
Right. Now, here one point, Saroja, I want you to highlight in your clinical practice, when you say healthy lifestyle, what exactly do you tell? Because in nowadays, even with the PCOS guidelines, they are the SMART objectives, means they have to be specific and they have to be
and
measurable. Right.
So I would say if it is minimal exercise or moderate exercise or severe exercise, depending upon the type of exercise. If if it is severe exercise, we can just ask them to do it 3 times a week. If it is moderate exercise, it depends upon the number of hours that we tell them.
Right. So moderate would be, anywhere between brisk walking to running to swimming. And that has to be the duration that you've mentioned. We are practicing in Delhi, and I'm sure in most cities, most women have their smartwatch with them. And I tell them that the sedentary people, their step count won't be even 2,000 or 3,000 steps a day. So please increase it to at least 7,000 to 8,000, if not 10,000. And also give a specific meal pertaining meal plan. Though it's not always mandatory to follow that, but at least it's a target they can look depending on their culture and whether they are vegetarian or non-vegetarians. Now, Anju, what is your opinion on various supplements that are used in these women? What do you use, and what is your clinical experience on their outcome?
Ma'am, I usually use folic acid and vitamin E or vitamin C, coenzyme Q, and nowadays also using EQOQ for better response.
How long do you give it?
Ma'am, I start just as a pre-treatment and for continue till embryo transfer, and also after pregnancy is positive, then also continue for 12 weeks onwards.
Shweta, do you have to add anything on this?
Madam, I would like to add DHEA supplement for at least 3 months. That is 75 milligram OD in OD dose. We can add melatonin in low dose, like say 5 milligram OD, which are nowadays in combination with DHEAs, they are available. I would specifically like to add vitamin D supplement that should be 60,000 international units weekly for at least 6 weeks. It would be better to add vitamin D supplements after testing, but considering Indians being deficient in vitamin D, like say 98-99% of population is deficient, so we can add vitamin D even without testing. And CoQ10 supplement, coenzyme Q10 supplement, 300 milligram OD for 2 to 3 months at least should be given for a patient of low AMH to anticipate and to expect and to have a good effect of antioxidant on AMH, or if not AMH, we can expect good quality of oocyte retrieval during pickups with these supplements.
Right. So the data on DHEA and CoQ10 is, coming up in a big way. And so we will just come to the various dosages and all have been mentioned already. The fertility option, Dr. Pratibha. So this lady, she was, what was her age? I think she was in her 30s.
32.
32. What is your personal opinion on offering IUI to these women who have a decent sperm count, the tubes are open? Would you, in a women with low AMH, offer that first before going to IVF?
In a patient of low AMH patient, there is very less chances of going for natural conception or IUI. I also have done many in patient, but the results are not very good because the quality of oocytes are also very poor in the patients of low AMH. So we have to consult the patient for embryo pooling also, and all we give double stimulation and will pool the embryo and will go for IVF only. We don't want to give a trial of IUI in a patient of very low AMH.
Yeah, I would tend to agree to that because time is of essence. And the way I explain to the patients is that your AMH may be, downhill curve, maybe, we don't know. And it is best to utilize the most effective fertility option initially. Whether we get the result or not, we don't know. But at least we should not wait till it has gone further down and your chances will become less than what it is today. However, still patients would sometimes insist on going on less invasive ART methods, and a few cycles, 1 to 2 cycles, is something that we may consider if the patient insists. And few studies, very few, most are saying IVF is better than IUI, but some studies have said that IUI may also be effective. Now, this is the protocol, and Saroja and Richa, I will take both your opinions on your personal experience of which protocol you like to use in these women. First, Saroja, can I hear from you?
Yeah, I'll go with the antagonist protocol, madam, because I'm using it a lot. So I'll preferably go with the antagonist protocol. And I've seen good results with the antagon protocol.
Okay.
So what drug and what dose?
So, usually I decide the dose depending upon the age. Obviously, this patient age is 32, depending
Mhm.
upon the duration of fertility and depending upon her BMI and looking at the previous response, how she has responded. So, majority of my patients in UK, when I worked, we used to give 150 and they used to really have a good response. But here I don't see that response. So, I start with 300 units.
And is it HMG or FSH?
HMG. ma'am.
Okay.
And it doesn't
Richa?
matter
Yeah.
his HMG or recombinant FSH, it doesn't matter.
So, Dr. Kaberi, I was actually using antagonist protocol till last 1.5 years back. Since then, I have switched on to PPOS protocols. And what I have seen in my practice is that PPOS protocols are actually giving us better results, better M2s, and the overall the burden of the citrulix and the antagonist injections have gone down. And regarding the starting dose of the gonadotropins, I would usually start with 300 recombinant FSH. And depending upon her baseline E2 and LH and FSH, we have to see whether she is hypo or what is the situation there. And if she's elderly, maybe more than 35, I might add on to 75 units of LH to have a better result. This is how I start, and from day 2 we start with the progesterone down regulation.
Right. Shweta, what is your opinion on the agonist cycle for poor responders?
Madam, I've seen, I mean, in my experience also, as well as the trials which we read, that stimulation with antagonist protocol or stimulation with GnRH agonist protocol, long dose protocol, or giving ovulagens with gonadotropins, all the protocols give similar results and they all are equal as far as M2 oocyte retrieval is considered.
Right. There have been some studies that have recently shown that agonist cycles in poor responders may give us slightly better response. But like my panelists, even we start with the antagonist cycle. And if that hasn't worked well, we go to an agonist cycle. We do add growth hormone and, sometimes the flare protocol also. So we are, anybody here does duostim because we don't do it. We tried it. We didn't like it. We stopped it. So any of my panelists are still doing it, and what is their experience on it?
Madam, I have done duostim, but duostim, I personally also didn't find it very useful. As well as the ESHRE guidelines of 2022, they also recommended that duostim shouldn't be done.
Right. Now,
So, we also did in 2-3 patients dual stim, but we felt like FGF from the first cycle was interfering and the patient was having discomfort. Not a good experience doing dual stim for me.
I have
See,
also not good experience, ma'am. Regarding dual stimulation, we don't get much result. It's better to stimulate in next cycle and you will get good quality of the cohort than stimulating in the same cycle. It's not giving good results.
Yeah, I think so. We all agree in it that our experience with the duostim has not been as good as we were expecting it to be. Now, the other thing, there's a beautiful paper on duostim which has done a SWOT analysis of it, and in which they have given that one of the weaknesses of the duostim strategy is that you are actually, even though you've done your pickup and then you are starting your stimulation in a few days' time, the second one, when you started in 4 or 5 days, sometimes there's a withdrawal bleed also. So whether the duostim is actually follicular and luteal or actual two follicular very close together is also a big question mark. So yeah, so we let it be that the experience so far hasn't been very promising. Now, this is my favorite, and we are doing a lot of embryo pooling in our unit. I would like to hear from Meeta, Richa, and anybody else So let's start with Meeta. Do you do embryo pulling? And if so, what are the stimulation protocols that you use? And when do you transfer these embryos?
Yeah, ma'am, we are doing embryo pooling, and in many patients we are doing. So, if in first cycle we got a good response with the intact protocol, so in the repeat cycle also we use the same protocol, and at the end, if we after doing 2 or 3 stimulations, if we get good number of embryos on day 5. Sometimes we have to freeze in first cycle if we have to freeze on day 3, and then in the next cycle again we have to if we get some 2 or 3 embryos on day 3, then all the embryos together to day 5, and on day 5 if we get 2 embryos minimum of good grade, then we go for the transfer in the next cycle.
Right. So the aim is to get at least 1 or 2 embryos of good grading. And if you get it in your first cycle, there is no need to do the pooling. You may even transfer to get. This is the consensus nowadays that if you're getting initially good embryos, even if the numbers are less, it's better to transfer. But even if you're not getting good enough embryos, it is better to go to the next cycle stimulation and then transfer in the second cycle. One thing that I've realized about embryo pooling is your counseling of the patients in the first meeting is very, very important. And once they are well counseled, then conversion to the next EP2 is very easy and smooth. But if you tell them on the day of egg cup or embryo formation that it's not good, we'd like to do once again, then it's met with a lot of resistance and disappointment. So anything else that my panelists would like to add here about their experience of embryo pooling?
Ma'am, some patients have told like we'll do 2 cycles even though they get 1 or 2 good embryos in the first cycle. They want to go ahead with another cycle so that they can use for further pregnancies like even after the first child. So I agree with them because the reserve might further like after they have child deliver after 1 or 2 years it might go down even more.
Yes, I would agree with that.
Ma'am, I will like to add something. If we are stimulating low AMH patients, the counseling is very important because the chances of cycle cancellations are also there. So we should counsel the patient at the first meeting only that definitely we are going to try. There may be cycle cancellations at any point of time. And if we get some embryos, then definitely we may have to go for embryo pooling to get a good success rate.
I think this is a very, very important point that you have to explain response to stimulation will be judged once it is to egg pickup. If we get M2s, then we wait for embryo formation. So very important point, Meeta taken. Yes, Richa or Pratibha?
Yeah, I wanted to add that first cycle we are giving conventional stimulation to the patients, and if we are getting good embryos, then second cycle definitely conventional stimulation is suggested. But if suppose we have an antral follicle count of say around 4 and 5, and out of all the conventional stimulations we are only getting maybe 1 or 2 M2s, and we are just able to make only 1 embryo, so I would prefer a minimal stimulation cycle in a next pooling so that her drug dosages are less, because in any which ways we are going to get 1 or 2 embryos only. So that is how I rationalize and kind of try to bring down the cost of the treatment also, depending upon how well her first cycle has responded.
Very valid point. Very valid point is that the stimulation protocol needs to be judged according to the response of the patient and your particular unit performance on the various stimulation protocols. And what we have seen is that, like I mentioned earlier, we do back to back. So we have antagonist, agonist, and then maybe a minimal or a flare. And in some women, and we are trying to, this is a publication process, in some patients, we have seen subsequent cycles have given us better results than before.
Yes.
So I don't know if that is a, finding of my colleagues as well.
Yes, definitely. We have seen that our second cycles have better embryos as compared to the first cycle. Maybe that we have been putting them on supplementations and the nutraceuticals to kind of increase our ovarian reserves and the quality of the eggs that we get. And I think majority of them have better embryos in a second cycle as compared to the first one.
Wonderful. I think we need to move on. So now, so let's ask Anju and Pratibha, what is your opinion on PRP and stem cell in these women? When do you do it? And if you do it, when do you do it? And how do you do it? So Anju can start. Yeah, Pratibha, please carry on.
In cases of low AMH, we use ovarian PRP, but I have never tried for stem cells, but results are not very optimal even after PRP also in cases of low AMH. It is still in experimental, and so I don't try much ovarian PRP in cases of low AMH.
Dr. Anju, what is your experience in this? So anybody else would like to comment on this?
So patients who are in the perimenopausal age group, or basically I limitize my patients till less than 42 or 43 years of age, 37 to 42, 43 bracket. And there we discuss about the ovarian PRP, but we do tell them about the success rates because as Dr. Pratibha said, it's still in the experimental phase. Many of the patients do respond and many of the patients still do not respond. So we first take them on the we take first cycle of PRP with them, and give them on medications for the 3 months. Then we again review. If there is a response, we go ahead for the second session. If there is no response, then a proper discussion is being done. Patient still wants to pursue, we go for the second cycle. But personally, in my experience, after 2 sittings of PRP, I would like to assess if there is a response. I would like to go, else we will switch to ODs as compared if there is no response.
Right. So there are 2-3 points here. One is in the country, if you are processing the cells in your own lab, then it is all right, but you cannot send the cells outside of your own lab according to the law. Then it has to come in the realms of clinical trials. So if you are processing in your own center, you can try it, but explain it to the patients clearly that it is still in the experimental phase and we are not sure of the benefits. There have been few studies that have shown significant improvement of PRP and stem cells, and most people would do a transvaginal approach if the ovary is clearly visible on TVS, but would prefer the laparoscopic route if the ovaries are smaller and not accessible so easily on TVS. Our experience also has not been very much to allocate about. However, the few results that we have seen post PRP and stem cell has been in the younger population. And so whether they would have anyways gotten pregnant without these interventions is something that needs to be debated. Right.
Ma'am,
So
one more thing I wanted to add was, suppose if we are doing transvaginal PRPs for patients for ovarian PRPs, we thought like better to stimulate the patient little bit so that the ovary is slightly bigger and it doesn't move away when we puncture with the needle.
Very, very interesting thought and idea. Yeah, it becomes clearly visible, and then you can put it on the various, at least you have to use 1.5 ml of PRP,
Yes,
1.5 ml of stem cell, and you need some area to put it in. And yeah, so I've not read of this happening, but I think, yeah, it's an idea worth discussing, at a later fora. So that's excellent. So now this is one of my favorite questions, and by this time, I think most of us are quite clear on what to do. But let me ask Dr. Saroja this question, and this is a 30-year-old. She's had 3 failed IVF, and she's come to you with the MRI report of a large fibroid, intramural, say about 6 centimeter. The MRI film that I'll show you is bigger, but say it's about 6 centimeter, but the cavity is not getting indented. would you consider myomectomy and why?
Ma'am, like if it is less than less than 5 centimeter, I wouldn't consider 5 myomectomy, but like the range is like 6 to 7 centimeter, and she has failed 3 IVF cycles. So I think we would go for myomectomy in this patient.
So Dr. Saroja says anything less than 5 intramural
I mean,
with
if
3
it is
failed,
not cavity distorting.
non-cavity distorting, but more than 5, we will remove. Right.
So if it
yes,
is
please.
cavity distorting, even smaller ones we tend to remove. But if it is not cavity distorting, until less than 5 centimeter, we leave it. More than 5 centimeter, like 6 to 7 centimeter, we'll do myomectomy.
Yeah, these are non-cavity distorting. That is very clear that they are not distorting the cavity. Yes, somebody wanted to add in something?
Yes, madam. Dr. Shweta.
But
Even if the fibroid is less than 5 centimeter, but it is of like the slide also which you're showing, if it is FIGO 0, 1 or 2, then we have to definitely go ahead with myomectomy either through abdominal route laparoscopically or
No, Shweta, these are cavity distorting. We are talking of 3, 4.
Intramural. We're talking about intramural, whether to operate or not. Actually, the guideline says that in cases of previous IVF failure, one has to operate for a fibroid. But honestly, in my practice, what we feel is if it is not at all cavity distorting, we are not going to go for myomectomy for such fibroids. I don't know about the opinion of the other panelist.
But if the patient is having a history of recurrent IVF failure, then we can take an option of doing myomectomy, because the size is also 6 centimeter. If anyway the patient will conceive, it will go for abortion or premature delivery and all. We should take an option of that.
The case which
all right, let's come to the conclusion here because we are short of time. So we are talking about 3, 4, 5, and maybe 6, but this is sub-serous. And it is, see, this is a woman that you've done a TVS. There's this fibroid glaring into your eyes. She's at 3 failed IVF, and it's not distorting the cavity, but then the consensus and the literature is clear. And please convey it to your colleagues as well. You have to remove these fibroids. And even if it is I think, Saroja, you were right. It started with 5 centimeter, but now it has moved on to 3 centimeter and above. This is a study which was in women's health, biomedical research, human reproduction, meta-analysis of the effect of intramural fibroids without uterine cavity, and you need to remove them, especially with repeated IVF failures. Right. So now, Richa, this is a very simple question. I would like you to highlight there's a patient with endometriosis. She's had laparoscopy, and she's having fertility issues. You have decided to go for IVF. What are the things you will keep in your mind when you do IVF for a patient with endometriosis, right from the protocol and the preparation during egg pickup, etc.?
Okay, so since it's a case of endometriosis, first of all, I would like to down-regulate the patient by giving her a dose of leupride so that her effects are minimal. And then when she has her next cycle, and we are going to start with the protocol. Protocol choice could be an antagonist protocol, and also depends upon the individual specialist choice. But I preferably do PPOS in such patients as well, and I have seen good results. Now coming to what is important is during the pickup and the procedure. First of all, sanitization of the canal should be with betadine so that the infection has to be taken care of. We have to make sure that she has received antibiotic prophylaxis before the start of the procedure. Third, while doing our pickups, we have to be very sure that we are not puncturing the endometriomas, and we try to avoid such punctures, and we try to keep the punctures minimum, and a good antibiotic prophylaxis post-opio.
Right. Dr. Anju, are you still here? I think she's not here. So, You're here, right?
She left, madam. She left.
Okay, okay. So let me ask Dr. Pratibha Shweta, that was wonderful. I think you highlighted this betadine, and this is a very simple step which all of us must do for endometriosis. And once we clean with betadine, don't forget to have a thorough wash with saline because we don't want that needle to go with the betadine into the follicles. So that is very important. And I'm a little, thoughtful about your protocol of down regulating and then going to PPOS. So, Meeta, you want to say anything? And what is the protocol that you follow?
Mostly in these patients, ma'am, I use NTAC protocol, and if required, someone might use long agonist protocol also. Sometimes we can do a single dose of Lupride, and then in next cycle we can just go and stimulate with the ovaries. Most of the times I use NTAC protocol only.
So, when do you down regulate?
No,
You don't
if
down
I
regulate.
use NTAC protocol, no. I just give an estrogen priming and then I start with the antagonist protocol.
And when do you transfer? Do you transfer in a down regulated protocol?
Yes. Once the embryos are freezed in the later cycle, I down regulate first and then give an HRT for FET and then transfer.
Okay. So the studies are very clear that down-regulated cycles in endometriosis fare better. And yes, they may come on day 1, day 2, and you may have given, you can do your stimulation, you can collect your embryos, but your transfer has to be in a down-regulated cycle for more optimal outcomes. So down-regulation, you can either do the continuous down-regulation from day 21, where it is the agonist protocol basically, but the suggested protocol is at least long down regulation for 2 to 3 months prior for the best results in endometriosis. Now we will wind up with a quick case, here, this one and the next one, but here this is male infertility, and I want to ask Dr. Pratibha that this is a patient with OATS and you are deciding to go for IVF with ICSI for this patient. What are the factors you will keep in mind to optimize the success rate for this patient?
Since this patient is of oligoacidoteratogenesis, the chances of patient, if patient is planned for IUI, then we cannot able to select the good quality of this sperm. But
yes.
Directly. So in cases of oats, we counsel the patient to go for either DNA fragmentation index to see that whether its DFI is normal or not. If it is normal, then we'll give the patient option for to go for IUI. Otherwise, we'll take counsel the patient for IVF and ICSI. And in patient with ICSI also, the result, sometimes results are good, sometimes the results are not good in cases of the oats also. So, and then we'll counsel the patient and we'll give option for TISA also, because in TISA also the chances of good quality sperm is better than that of the directly from the semen.
So Saroja, how will you optimize this? You've decided to go for ICSI. It's severe oats. You cannot do IUI. DFI, I know, is a plus minus in today's world, but it has its various roles and implications. So what would you do to optimize is my question again.
So first again start with the counseling and the lifestyle factors again here. Like with the female factor, so we can counsel them like again optimal weight. If there are many medical disorders like diabetes or hypertension or any immunological disorders, to control them and have a good thing. And then again diet, exercise, and stop smoking, drinking if there are anything. And specifically nowadays, if anybody is going to the gym, I'll ask whether they're taking any testosterones or anything, and optimize that aspect. Then after that, we'll do a clinical examination to see if there is if the testis is palpable or not, if the vas is palpable or not, and get an ultrasound examination. Sometimes there might be underlying testicular pathologies too, and do a hormonal profile, FSH, LH, and see how the testosterone levels are. If the testosterone levels are low, I think these patients would be beneficial by taking treatment like clomiphene citrate or letrose with HCG injections. They would be beneficial, and nutraceuticals in some patients will be helpful. We are not sure, but because the harm is less, we tend to give it. And in the scan, or if there is any palpable varicocele, or if the patient is symptomatic with the varicocele, we'll refer them to andrologist to get a varicocele repair. And if the counts are too less, if it is less than 5 million, we do the testing for karyotyping and Y chromosome microdeletions to see if there is any problem. Then we counsel them regarding what is the best prognosis. And we say like, okay, there are other techniques in addition to ICSI, like PICSI, MAX, that can help with the better selection of the sperm in these patients.
Fantastic. I think, Saroja, you have covered most of the things. And the importance of this case was that as infertility specialists, we are seeing both female and male. And it is very, very important to optimize both to get the best outcome. Smoking, lifestyle, adjuvants, varicocele repair for grade 3, grade 4, infection screening, short ejaculatory abstinence, testicular sperm wherever needed, genetic testing, all the arginine, CoQ10, all these things which may help. CoQ10 is coming up in a big way. L-carnitine is coming up in a big way. And very important to measure the testosterone, estradiol in severe oats, and if there are less, then the role of aromatase inhibitor, the role of HCG, the role of FSH to further optimize the sperms to give the best outcome is what we needed. And wherever it is required to do the PGTA or PGTM as required. So that was an excellent, description, Saroja. And this is one of the last questions to Richa and to all my panelists. And I think this is somewhere in our OPDs, we in the rush or, we forget to ask few questions to the male partner. So what precautions would you follow and consents to ensure that there is no problem on the day of sperm collection?
So whenever I'm taking a patient, such kind of a patient who has a history of oats, and during the stimulation process, I've done a baseline semen analysis. So for the collection on the day of pickup, I would first ensure that patient did not have any ejaculatory dysfunctions prior. We would counsel 3 days of abstinence to the patient. We will rule out any other associated UTIs or any infections present in the or any complaints with the patient. And we will prefer the collection of the sample within the premises and will not prefer home collection. And in cases where they have an ejaculatory disorder or they have difficulties in giving the sample, we will try to freeze it prior to avoid any end time cancellations. And many a times when the fragmentation levels are high, or maybe we are not getting to so in that cases, sometimes we also repeat the ejaculation. Maybe it is always seen that the second sample which has been given has a better sperm quality and a lesser fragmentation. So this is how we move forward. And if and I would like to add on one point here, that just previously discussed that we were discussing that whenever DFIs are high, the testicular sample is required, but the recommendation says that initial 1 or 2 cycles of IVF, if possible, can be done through ejaculated sample should be preferred, and we restrict TISA or TSA only to people who have failed previous 1 or 2 cycles with the ejaculated sample. So this is, and consents, of course, we will all take it prior. Before that also has been already done on day 2. So this is all we follow. Anything to add on, anybody can take care.
No, fantastic. I think two important points. Please ask the partner whether giving the sample at the center is a problem or not, because some men do have that problem. So you may freeze the sperm earlier. They can get a home sample, but whenever you get a home sample within 45 minutes to 1 hour, and a signed consent that the both from the husband and the wife, that it is their sample and they agree, this is what they have agreed to give it to us for later on any litigation to the center or anything. And a short ejaculate. So severe oats, you give the first sample, the sperm motility is not good, the embryologist is not happy. After half an hour, take another sample if possible, and you will see that has better motility and better results. So I think we will stop at this because we could go on and on and on. But thank you, Anu, for giving us extra time. And I think it was very, very interesting and enjoyable with my panelists. Thank you, my panelists.
Thank you so much.
Thank you, ma'am. Thank
Thank
you.
you so much.
Thank you,
Thank
Kaberi,
you,
We
ma'am.
also
for that
enjoyed it.
wonderful panel.
Thank you, Dr. Fessy. Always
Thank
nice
you,
to
Dr.
be in your
Kaberi, and
panels.
all
Yeah.
panelists. Very
Thank you so
interactive.
much.
Very nice.
Thank you.
Thank you. Thank you once again.
So
Thank
I
you once
think,
again,
Yeah.
everyone.
okay. Nakul,
Thank
you
you,
can
doctor.
conclude.
Thank you very much. Yeah. Shall I share a thank you note?
Yes, yes, yes.
Yes,
Thank
yes.
you, Dr. Fessy and Dr. Anu. First of all, thank you for being here tonight for the 7th series of our ISAR UNS Fertility Catalyst webinar. And absolutely, your presence made the event truly special. Today, we have attracted participation of 443 doctors from across the India. And I would like to thanks to our distinguished speaker. Special thank goes to Kedar sir for valuable contribution. He has discussed about the optimizing gonadotropins in IVF. Definitely, Dr. Sachin nicely elaborated about the role of letrozole in infertility. And special thanks to Dr. Kaberi for sharing her immense knowledge and insights on effective strategies to enhance the IVF success. Thank you, doctor. Also, I would like to I'm grateful to thanks Dr. Amit Patri, Dr. Bakshi, Dr. Anu, and Dr. Fessy. I must thanks. And today's chief guest, Dr. Reshma, and Dr. Guest of honor, our Dr. Parag. So thanks, and your support is invaluable to our mission. And definitely, we look forward you in our next webinar.
Thanks,
Thank you.
Kaberi ma'am, for joining us.
Okay. Thank you.
Thank you, Dr. Kaberi. Thank
Thank
you,
you,
Dr. Anu.
Dr.
Thank
Fessy,
you.
Dr.
Thank you all
Anu.
the panelists.
Okay, good night.
And thank you, UNS, for organizing this. And thank you,
Thank you, ma'am.
ISAR.
Thank you.
Okay, bye. Bye.
Thank you. Good night.
Good night.